Hi, my name is Sophie Harding. Thanks so much for asking me to come to speak today. I'm the pharmacogenomic lead at the Royal Pharmaceutical Society, which is a GB role covering England, Scotland and Wales. I'm leading on a programme of work about ensuring advocacy and policy for the role of pharmacy in pharmacogenomics, and also ensuring educational resources and awareness among the profession. Just to explain, before going into pharmacogenomics, to explain the background around genomics within healthcare. So in 2020, a Genome UK strategy, a 10-year strategy, was launched by the UK government, and that provides vision and outlined strategic aims to create an advanced genomic healthcare system that delivered better health at lower costs for patients across the UK. And all 4 nations signed up to this UK strategy. The strategy, more specifically to pharmacogenomics, describes a preemptive approach to testing and ensuring patients have a pharmacogenomic profile within their medical records. So going back further than that, in 2017, the Welsh Government launched a Genomics for Precision Medicine strategy and set up a year later the Genomic Partnership Wales. And as you can see from the right-hand side, this is creating a partnership within key organisations to lead on implementation of genomics within Wales. So the All Wales Medical Genomics Service is a key organisation within Genomic Partnership Wales, otherwise known as AWMGS. And AWMGS is an NHS specialist regional health service, which is based currently within Cardiff and Vale, which consists of a clinical team which work with clinicians from across Wales, across all sectors and across all health boards and trusts to help and support patients in Wales who have genetic conditions or may be at risk of developing a genetic condition. The ORGOG and NPGG are 2 sister groups which sit underneath the All Wales Medical Genomics Service. So the All Wales Genomics Oncology Group is a group of experts from across Wales who lead on the implementation of pathways for the use of genomic testing related to certain oncology or haematology drugs. The National Pharmacogenomic Group is another recently developed and set up group which leads on the implementation of pharmacogenomics within Wales. Just wanted to also mention there's a key role for genomics within healthcare, and the future is to look forward to better prognosis, fewer adverse events, better diagnosis and better disease monitoring, etc., as you can see from the diagram on the left. We're moving forward towards a more data-driven, value-based healthcare, and a healthcare where patients receive more tailored treatments and medicine optimization and shared decision making is taken into consideration. So just to really outline the key terminology used within this presentation and within genomics. So genomics is the study of an organism's genome, its DNA, and how that information is applied. Pharmacogenetics and pharmacogenomics are 2 terms which are often used interchangeably, but are slightly different. So pharmacogenetics is how variations in one single gene influences the response to a single medicine. And very often currently, that is where pharmacogenomics is currently having a place within healthcare today, before we move forward towards panel testing. Pharmacogenomics, or otherwise known as PGX for short, which is slightly easier to say, is a study of how an individual's genetic information determines how that individual manages and responds to medicines. And as we're all aware, personalised medicine is about individualising drug therapy in light of genomic information, but also taking into consideration diagnostic and clinical information, because pharmacogenomics obviously is another tool within our toolkit which we need to consider, and we still need to take into consideration other key clinical information and diagnostic information. In order to obtain genomic information to deliver personalized medicines, we need to know and we need to obtain a sample of that patient's blood, often, or saliva sample within pharmacogenomics, and that's taken obviously directly from the person. Or within cancer genomics, the difference would be taking a biopsy potentially, or working towards a liquid biopsy in the future within cancer genomics to determine if a patient is likely to respond to a medicine by looking at gene variants within their cancer tumour. Or within pathogen genomics, we would be testing and looking for gene variants within the infective organism. So pharmacogenomics is what we're due to talk about today, and pharmacogenomics helps us to select the most suitable drug and dose to achieve a better therapeutic response. So pharmacogenomics brings together the pharmacology of the drug, so the pharmacokinetics and pharmacodynamics, with the genomics, so the genomic information, to tell us how to appropriately and safely treat patients tailored to variations within their genes. And as you can see from the graph below, the type of drug response achieved obviously depends on what type of metabolizer that patient is. So if they're a poor metabolizer, to the other end of the scale, to an ultra rapid metabolizer. So as we all know, drugs can be prodrugs or they can be the active drug. So the prodrug is obviously converted into the active form as an active metabolite, and codeine is an example of this, which is metabolized by the CYP2D6 enzyme. So if a patient's a poor metabolizer of CYP2D6, they're not able to convert that codeine as a prodrug into the active form, and therefore the patient will have a suboptimal response or a lack of effect. And clopidogrel is another example of this as a prodrug. An active drug such as warfarin or omeprazole obviously needs to be inactivated in order to reduce toxicity or reduce the risk of side effects. So that active drug for somebody who's a poor metabolizer can't be inactivated, and therefore you have increased risk of toxicity and side effects when taking that drug. So as an example of pharmacogenomics in practice, I was involved as one of the co-leads alongside two senior consultants and a project manager to implement DPYD testing pathways within Velindre Cancer Centre as a pilot site for all of our patients across South East Wales back in the early 2020, and this is prior obviously to my RPS role. Prior to implementing the test, patients didn't receive a DPYD gene test, and they received fluoropyrimidine chemotherapy, so a certain type of chemotherapy. And that chemotherapy could potentially, if a patient carried a variant, cause severe and life-threatening toxicity. So when we implemented the DPYD testing pathway and we tested patients prior to them receiving fluoropyrimidine chemotherapy, then we could determine how that patient was likely to respond if they did have a variant for the gene. We are then now able to choose an alternative treatment if appropriate, or to dose reduce that patient to enable them to manage and reduce the risk of severe toxicity, hospitalization, death, or obviously use of rescue drugs. So a nice clear diagram to compare the pharmacogenomic approach that we've described, which would be to be performing a pharmacogenomic test or a panel test, hopefully embedded within patients' medical records prior to prescribing a new medicine, can help to to ensure that the right medicine at the right dose is achieved for the patient, compared to the standard current approach where we use very much a trial and error approach to stopping and starting or lowering doses to ensure that the same outcome, the right medicine at the right dose. And this diagram is a really neat diagram which came from the personalised prescribing document produced last May or launched last year by the British Pharmacology Society in partnership for the Royal College of Physicians, and it's probably a key document for if you're interested to read further, to explore further implementation within the UK for pharmacogenomics. Although there's key benefits to implementing pharmacogenomics within healthcare, and obviously these key benefits would be to improve patient care and compliance as we're using less of the trial and error approach and using the most appropriate treatment, hopefully more upfront, to potentially reduce medicines wastage as a result, to reduce the impact on healthcare as we may need to see patients less often or less frequently, potentially, if we're using the most appropriate treatment sooner, to improve drug safety, and also we're moving towards the vision within the Genome UK strategy that we can perform a test result once per lifetime, so we can personalise a patient's treatment. But there are key challenges to implementation of pharmacogenomics. We need to ensure that there's access to the test, whether that's through the NHS or privately, although there are concerns around direct-to-consumer testing and the accuracy of direct-to-consumer testing and the ethical issues around purchasing a test, being able to be tested, and also data management, issues around transfer and interoperability and transfer of data from the laboratory to the clinician who then needs to action that result, and also the accessibility to healthcare professionals across all sectors of healthcare. Also interpreting test results, so the accuracy of and the knowledge of that clinician, enabling them to interpret that test result appropriately. Obtaining consent, if we're going to take a panel test, have we got consent for the other genes that are tested on that panel test, rather than if we're just asking for one specific single gene test result. Also, there's a lack of research in this area in the UK, and also a lack of research within certain populations. So we haven't got that population diversity data that we may need to show benefit within practice. We also need to upskill the workforce to help with lots of these key issues, especially around interpreting test results, and obviously informing not only the workforce but also the patients and public. And obviously all those key things fall into education. So we need to look at undergraduate training as well as postgraduate training. Thanks. I think I'm over time, but thank you so much for listening. It's very difficult to incorporate everything that needs to be discussed within 10 minutes. I'm slightly over, but I'd be happy to take any questions. But also, if you wanted to contact me later, these are my contact details with my NHS email or my Royal Pharmaceutical Society email. Thank you very much for listening.